Good morning. Today we will see about ovulation induction. A woman with irregular infrequent menstruation is supposed to have an ovulation problem and that needs to be treated with ovulation induction drugs. When an ovulation is the only problem, this regimen is okay. But a woman with oligomenorrhea will not respond to this ovulation induction because she might be having associated or coexisting other factors of infertility. So a proper evaluation has to be done. So in pre-treatment evaluation, we rule out diabetes, we rule out other uterine and other factors by doing ultrasound or HSG, and also we give advice of lifestyle modification before applying this ovulation induction drugs, because even modest amount of weight loss, that is 5 to 10% of the weight loss, can restore normal ovulation in obese and ovulatory women. So what were the options available? Back in 1935, Steen Leventhal, he did bilateral ovarian wedge resection. It was called as ovarian drilling nowadays. So he removed tissues from both the ovaries. The tissues that produces the androgen were lost. So the androgen concentration in the intra-ovarian and in the circulation were reduced. So that helped improve fertility. So this method came to a halt when a wonderful drug called clomiphene citrate emerged in 1967. It was considered the drug of choice for ovulation induction in women with normal thyroid, normal estrogen, normal hormonal profile, but ovulation is the only problem. And it had some side effects and resistance also developed. So then came a drug called as aromatase inhibitor, that is the letrozole, anastrozole. But both these drugs had similar rate of miscarriage and the similar rates of multiple gestation. And then they introduced exogenous gonadotrophins, that is, they prepared human menopausal gonadotrophins from the menopausal urine that contained equal amounts of FSH and LH, 75 international units. But then it was purified until it contained lesser amounts of LH, that was 0.001 international units of LH, with absent or minimal urinary protein which could be administered subcutaneously. So the purification happened, and then they did a recombinant method. The gene for FSH production was introduced into the genome of the Chinese hamster cell line, and they produced the FSH that was glycosylated and purified by immunochromatography and was supplied. It was less acidic and it was having a lesser side effects, and the variability in biological activity was batch to batch variability was less because it was all the same, and the effectivity by which it causes estrogen secretion was better than the urinary extracted method. So there were names like polytrophin alpha, beta, which were prepared from the Chinese hamster ovarian line, and polytrophin delta was prepared from the human cell line. And then they made a chorepolytrophin, that is the gene for FSH, and the gene for beta HCG C-terminal peptide was introduced to the germline, and they produced the thing. So all these things have prolonged the half-life and they have enhanced in vivo bioavailability, but the only problem is they are indicated when multiple follicle stimulation is needed and not for unifollicular or monofollicular stimulation. So why they had FSH and LH. FSH is for ovarian follicular growth and oocyte maturation, and LH is for steroidogenesis, luteinization, and ovulation. So there are people who respond to a relatively low dose, so they may be hypersensitive. They will end up in ovarian hyperstimulation syndrome, and the dose and the timing has to be appropriate, because if you apply a HCG injection before LH surge, instead of causing follicular development, it will cause atresia. So it should be properly timed and the dose should be adjusted clinically as per the patient's endocrine factors. So there are many regimens: step up regimen, step down regimen, coasting, adjuvant treatment. So step up regimen is where they start with a low dose, 75 units daily, and then for 4 to 7 days they give it. They measure the estrogen level and the follicle size. If the follicle size of the dominant follicle is 18 to 20 mm, then they put the HCG injection, and after 36 to 40 hours they see for signs of ovulation. If it has happened, okay, then they go for IUI or natural conception. If it does not happen, the cycle repeats. So we said women with PCOS are hyper responsive to the exogenous gonadotrophins, so they need a lower dose. That was called as low slow treatment regimen, that is 37.5 to 75 international units daily for a period of 7 to 12 days, and then they measure similarly. Step down protocol. So what is with the step down is, initially they give high dose of FSH, so multiple follicles will grow, but only one follicle will be overly sensitive to the FSH. So after some 7 days they will withdraw the FSH, so or they will reduce the dose so that the one that is very sensitive will grow, whereas the one that require high amount of FSH will go for atresia. So that results in follicular growth. Sudden stoppage of FSH before LH injection is called as coasting. It is based on the concept because FSH when given to the ovary will stimulate the LH receptor expression. So once it is withdrawn, once it is given in a higher dose, it is going to improve the LH receptor expression. After the FSH is taken, LH if it is given, LH is going to act upon the LH receptor and it will cause ovulation. So this method is called coasting, and this method helps to avoid ovarian hyperstimulation syndrome. Then we have sequential treatment. Initially clomiphene citrate, then followed by HCG, or adjuvant treatment. Initially GnRH agonist, then gonadotrophins. But this is all more theoretical. It all depends on the clinical judgment of the patient. So then after this gonadotrophins, they started another drug called as gonadotrophin releasing hormone, pulsatile GnRH administration, that is in 1980s. It was very costly. It needed an indwelling catheter because it has to be given in a pulsatile manner every 60 to 90 minutes, because it has a T half of 10 to 40 minutes. It comes in a crystalline form that has to be diluted and given at a dose of 2.5 to 5 microgram per pulse. Maximum of 20 microgram can be given, and this is indicated in anovulatory infertile women with hypogonadotrophic hypogonadism. And last we have dopamine agonist. So hyperprolactinemia can cause anovulation, so we give dopamine agonist to reduce the prolactin levels. We have bromocriptine and cabergoline. So next we'll see the presentation for better understanding.